Hello to everyone who's joined today. We're just waiting for a few more to join and then we will get started. Thank you for attending the webinar from CJ Medical. We're really excited to be hosting this today, and a special thank you to Professor Bhaskar, Professor Joe Phillip, Yuko Smith, and Mr. Ananda. Well, I am now going to hand it over to Bhaskar.
Thank you so much, Phoebe. Thank you, friends, colleagues. Thank you to CJ Medical and Pearson for supporting this webinar, and to the panelists, Professor Joe Phillip, Yuko Smith, and Ananda Dhanasekaran for being a part of it. Really, what we're going to discuss today is the role around single-use scopes, suction sheets, scopes, etc. And at the end, if you have any Q&As, please feel free to write in the chat box or Q&A so we can answer you. The idea is to try and see how the suction, the scopes, the technological innovations have moved and pushed the boundaries further and further. So without further ado, I'm going to hand over to our first speaker, Mr. Ananda Dhanasekaran. Ananda, when you're ready. Thank you.
Thank you, Bhaskar. So we will start the show with something quite basic and simple. I'm going to discuss on the single-use cystonephrovideoscope. This is a kind of a paradigm shift because of the presence of suction and also minimalization. As you all know, we have just opened the new multi-billion Midlands Metropolitan University Hospital. I'm quite happy to welcome you all on behalf of our new hospital. So this is the brief content of today's presentation. We all know the cystoscopy is like stethoscope for a physician. Cystoscope is used not only in the dedicated theaters and also in the outpatient unit and endoscopy units for basic diagnosis. What is the role of these disposable cystoscopes? If there is a problem with the reusable scope, unavailability, not able to achieve the intended target cancer follow-ups because of the non-availability of the endoscopic suite slots, cystoscope damaged by accessories like using for stent removal, and cancellations and delays. So it's always quite handy to have a disposable cystoscope in the shelf. So there are various ways by which we can use this. People can sign up for a complete reusable cystoscope business case program or a kind of a hybrid. There are lots of publications on the cost effectiveness of the disposable cystoscopes. In 2018, we had 2 publications, both in BJUI, and it comes out with the take-home message of mean cost per case was only $395 for a disposable scope. If there is a repeat reusable endoscope use more than 2.5 times in a day, which can easily happen, say for example, in my unit, we run 2 hematuria lists morning and afternoon, and we have something around 12 to 13 patients in every list. In total, we have only 6 or 7 reusable scopes. So easily the rate of usage per day crosses 2.5. Not only in our country and also across the Atlantic, they have proved the economic advantage of disposable, flexible ureteroscopes when comparable to the reusable scopes. There are some clinics which are quite world standard, accepting disposable cystoscope as the present and future technology. Coming to this product explanation, it ticks all the boxes of the normal cystoscope. Along with that, you can see that there is a straight insertion channel. So if you're doing any outpatient-based laser procedures or even in theater, your laser fiber will be straight. So chances of in-scope breakage and in-scope damage will be quite less. And the main talk of the town today is the suction control. It not only gives a separate suction port and also gives a nice ergonomic design. During the cystoscope, because of this modern appearance and the ergonomics, we get optimal irrigation flow. The irrigation will be going through this port, and there is no need for any separate 2V we need to open, there is an attached safety valve. So it's very safe, effective, and it gives a very enhanced intraoperative vision. So this is an example of the vision. You can see that it is high definition and much more brighter than the normal cystoscopes, with a very good flexion of 210-degree both up and down. So the straight insertion channel, as I said, is a big prize winner, especially if you are using the laser fiber. And also, it also gives a good access for stent removal accessories. We got good image processing units, which gives excellent vision. And these units can also be connected to your existing stack system. It accepts all the normal accessories like biopsy forceps, cell brush for cytology, sampling needles, foreign body forceps, and also the laser fibers. When in comparison with the other competitive products, whether it's reusable cystoscope or other disposable cystoscopes, the PC200 outcomes are quite good. We can see that compared to the other reusable cystoscopes, the bending angle is quite good. And also the suction valve is also of quite high value. There is a separate liquid irrigation port. When you compare it with the other disposable cystoscopes, you get the maximum instrument channel width, 7.2 French when compared to others. And also the bending handle is better. It got the separate suction valve and separate liquid irrigation port. Clinical applications, we know it's quite useful for both TCC surveillance and also for hematuria clinic in diagnosis, stent removal, and also for the cytology. In upper tract, it's quite useful for PCNL to treat complex renal stones. It will avoid extra puncture and extra channels. Because of the bending angle, we are able to reach the other calyces which were not reached by the straight mini PCNL or standard PCNL sheets. I will show a brief animation to explain the versatility of this disposable cystoscope. So it is a single use. It's both for bladder and the kidneys, integrated suction valve, and there is an integrated T connector. We don't need any extra connectors. So the irrigation and suction are in different ports with a very ergonomic handle. 210-degree both upward and downward deflection gives you a good access. Suction helps to clear the vision, and similar advantages when you're using it in the PCNL so that additional ports can be avoided. Stent removal forceps can be easily inserted because of the good working channel, and integrated the 2V or the valve saves because we don't have to use any other extra accessories. So take home message, it's quite a very simplified cystoscope, boosting the efficiency and patient care, excellent, clear imaging, and efficient in its working parameters. I complete with this picture, which gives all the important advantages, and with special focus on the integrated suction port and innovative patented angle with excellent dual LED visualization system. Thank you.
Thank you very much, Ananda. That was great snapshot of the suction cystoscope. Just wanted to say that sometimes in our unit, at least, we are also using it after TULA because it helps with after the TULA procedure, the ablation of bladder tumors. And we are also going to trial it for local anesthetic bladder stone for the unfit patients. So you can try it. So there might be additional usage, which currently we are exploring. And I'm sure as people continue to explore, the cost of doing it in an outpatient setup will also minimize. Thank you very much for that. If people have any questions, please, for Ananda or for any of us, please put it in the Q&A or the chat box so we can answer them. And with that, I will invite our next speaker, Yuko. Over to you. Thank you.
Thank you. Are you able to see my slides?
Perfect. Thank you. If you can do it full screen, then it'll be even better. Right now it's on the mini screen. If you put it on the full screen.
Okay. Brilliant. Good. Hello there. My name's Yuko Smith. I'm a consultant urological surgeon at the Queen Elizabeth Hospital in Birmingham. And my remit's talking about minimally invasive PCNL, achieving the best outcomes. As you know, the EAU guidelines for urolithiasis recommend PCNL as a preferred option for stones of over 20 millimeters. And they also recommend endourological management with either URS or PCNL for lower pole stones of greater than 1 centimetre. So what's the definition of a mini PCNL? Standard PCNL with a sheath of 22 to 30 French has previously been considered to be the gold standard treatment for large intrarenal stones. The large access gives excellent visibility and the ability to break and remove large fragments of stone. The larger sheath, however, brings the disadvantages of greater blood loss. Mini PCNL sheath sizes of 14 to 20 French have now become the mainstay for managing intrarenal stones of around 2 centimetres due to the perception of reduced invasiveness, but there may be questions about whether the outcomes are equivalent. Ultra mini or micro PCNL with an access of less than 13 French will give increased manoeuvrability around narrow collecting systems. However, particularly with sort of suction access catheters with flexible ureteroscopy, there may be a question about how much a micro PCNL might add. So the question is switching down to a mini a trade-off between reduced invasiveness and outcomes? So how do we define outcomes in PCNL? Obviously, the stone-free rate is critical for our patients, and this will depend to some degree on the imaging modality used for follow-up. Time, so operative time. In the days of long waiting lists, our managers are keen for us to do each operation quickly and do more operations. And even from a patient point of view, there's a suggestion that keeping your operative time to less than 2 hours may reduce your complication rate. Post-operative fever and sepsis and other complications are clearly important to our patients. And blood loss is of key importance to our patients, both in terms of transfusion and angioembolization risk. Managers are obviously very concerned about length of stay. From our patient's point of view, post-operative discomfort will be important. In the cash-strapped NHS, there may also be concerns about the cost of the procedure, which will be a balance between the costs of consumables, but probably more importantly, the operating theatre resources. And so in comparing mini PCNL with standard PCNL, multiple systematic and meta-analyses have shown no significant difference in overall stone-free rate between mini and standard PCNL. However, standard PCNL had a shorter operating time in comparison to mini PCNL, and the length of stay was usually shorter with a mini PCNL. Post-operative urine leakage, blood loss transfusion was higher in the standard PCNL group, especially where the sheath is 30 French. Fever and embolization was not statistically different. We've all become increasingly aware of the importance of intrarenal pressure on post-operative outcomes. Compared to standard PCNL, where mean intrarenal pressures were less than 20 centimetres of water in this top study, animal models showed much higher intrarenal pressures in the mini PCNL models, and over 50 centimetres of water was observed. And we have become aware that pressures of 30 to 40 centimetres of water may produce pilovenous backflow, and with this, greater postoperative discomfort and infection rates. The bottom study was a porcine model where uropathogens were instilled into the renal pelvis during PCNL, and either a mini or a standard PCNL was subsequently performed. And in this study, they showed that in the mini PCNL arm, bacteria were found in the majority of the spleen, liver and blood cultures, compared to in the standard PCNL arms. And the concern, therefore, is that this may translate into patient outcomes. So in terms of mini PCNL with suction, here is a picture of the Pearson access catheter, and you can see that it comes as a one-step dilator, although you can also use smaller dilators prior to inserting the one-step sheath. It's connected to a suction bottle, and you have control for collection of the stone fragments. The suction's attached here, and you've got a lever here for control of the amount of suction, and here there's a finger port where you can close the port to increase the suction. I'm just showing a very simple illustration here. So you can see when the stone is fragmented, you get continuous suction of the debris, and then as you retract the scope, you can see that the larger fragments will collect into the bottle. The addition of suction may bring the advantages of reduced invasiveness of mini PCNL, whilst compensating for the disadvantages. Suction keeps the stone fragments close to the energy device, improving energy delivery and reducing fragment migration. It also aids the vision by continuously sucking out debris or blood, and it keeps the intrarenal pressure low and aids evacuation of the fragments. Here is an intraoperative video, and you can see that as the scope is retracted, some of the fragments will follow. Sometimes they need a little bit of a nudge to free them, but you can see how efficiently the fragments are evacuated, and you can see them leaving the port into the suction bottle just there. So what does the suction sheath add? Excuse me. In this single centre study below from the World Journal of Urology, they performed mini PCNL with and without suction. And in the mini arm and the standard arm, in some of the patients, they had a ureteric access catheter connected to a urodynamic machine so that they could monitor the intrarenal pressures. And they showed that the intrarenal pressure was kept below the threshold for pilovenous backflow throughout the operation in the arm with suction. With a mean cumulative time with the pressure above the threshold for pilovenous backflow at less than 30 seconds. And this was usually during the beginning when access was being attained before suction was connected. The meta-analyses and systematic analyses have shown that immediate and final stone-free rates are significantly higher in the vacuum-assisted PCNL. And they've also shown that shorter operative time, fewer axillary pressure procedures, and lower complication rate in the suction access group. So in real terms, how do we optimize the outcomes? Obviously, it'll be about case selection. Mini PCNL is ideal, where the stone is probably up to sort of 2.5 to 3 centimetres. The Hounsfield unit of the stone will matter depending on the energy device that you use. In terms of anatomical factors, it may offer advantages over standard PCNL, particularly in terms of narrow infundibula. and you get less collecting system trauma while manoeuvring around a narrow system. Mini PCNL is ideal where there are larger stones in multiple calyces that are less amenable for removal with a flexible scope. And you can get a flexible ureteroscope through the 16.5 French access sheath. Obviously, mini PCNL may be preferable in patients with a single functioning kidney or where blood loss is more critical. In terms of positioning, the supine position gives you a better sort of vortex effect, although this is ameliorated to a great degree with the suction access catheters. In terms of your available equipment, your choice of scope will depend on what you have available to you, whether you've got suction scopes available, whether you've got the mini access sheath, whether you've got the suction access sheath available to you. In terms of energy sources, the thulium laser does offer high efficiency with soft stones particularly, and there is some evidence to suggest that ultrasonic and the combined ultrasonic and impact devices may further add efficiency. In terms of available staff, obviously the surgeon experience is important, and there is a little bit of a learning curve, but not much to the use of the suction access in PCNL. Trying not to keep the system too collapsed so that you maintain your vision, obviously trying to keep your scope close enough to the stone to encourage it to move into the sheath, but trying not to rub against the mucosa, in which case the pressures can still build even with the suction. Obviously, if you want to perform ECRIS, then you'll need a skilled assistant. So in conclusion, optimizing outcome will be horses for courses. So picking the right procedure and the right access for each particular patient, being flexible in your approach. And as endourologists, it's always good to keep the kitchen sink on standby, using whatever we have available in our armamentarium.
Thank you so much, Yuko. That was very nice snapshot of mini PCNL and the role of suction in mini PCNL. And I agree, I think increasingly the guidelines are moving towards minimization. So the concepts of what was considered standard is now moving down, especially with high energy sources and suction and so on. So our next speaker, please welcome the President-elect, Professor Joe Philip, who is going to talk about single-use scopes and smaller scopes. Thank you, Joe, for joining.
Thank you, Bhaskar, for the invite, and thank you all for joining on this evening to listen to miniaturization. Let me share my slides. So for those of you who don't know me, I'm a urologist in Bristol, and also, as Bhaskar said, the President-elect. The remit of my talk is about small ureteroscopes and whether that's the future of endourology. So pertaining to this talk, I have no disclosures. I would like to bring to the attention of all the attendees about the factors that influence treatment choice. One has to be careful and cognizant about the availability of shockwave lithotripsy and PCNLs. It's about size, the site, the anatomy, the obstruction possibilities, and I come to that as we go along. And obviously, the resources available locally and also one's own success rates. And often, as now we are getting more used to it, patient preference. Whether they would like to have a single procedure with a smaller scope, with the likelihood of not having a stent, rather than multiple procedures. So this is our acute stone service pathway, which was submitted as a case report by the GERFT in 2023. And as you can see, a significant number of patients have ureteroscopic surgery because either they have stones that are not visible on X-rays for other treatments, or would like to have a single one-shot treatment. Now, over time, from 1964, when the proper first endoscope for the urinary tract was identified, we've reached a stage where with endoscopes that there are now flexible ureteroscopes with 7.5 French and potential to have even smaller. But the benefit of all these is that one can go into most ureters with a lower two-stage rates and a reasonably good working channel for good flow and introduction of instruments. But what are the disadvantages and advantages of these single-use scopes? In patients with multi-drug resistance, as some places in the world see, there is a reduced risk of contamination. There's the potential for teaching novices, so you're not risking a 10,000-pound scope by enabling educating and training your fellows, as you'll see in my next video. There is also a potential to use the flexible ureteroscopes in more challenging settings with the possibility of breakage, like in acute angles in the lower calyx, where the stone may be anteriorly in a calyceal diverticulum, where one has to do a secondary deflection to get to visualize the stone. I mean, the disadvantages are that in this modern stage of sustainability and disposable issues, the single-use scopes are becoming a major challenge on how we can minimize plastic degradation. Maybe the way forward would be a hybrid approach, especially focusing on challenging cases, patients with large stone burden, training cases, lower pole stones, and also in those with tight ureteral access, like patients who've had radiotherapy in the past. So this is a video, as you can see, this is the flexible ureteroscope in a BMI 40 patient. As you can see, the anesthetist is struggling to keep the tidal volume low. My fellow is using the scope, used to a reverse standard deflection. We use a standard deflection, that is down, up is up. And the whole idea is to laser fragment using reasonably high power this large lower pole and extruding into the renal pelvis partial stagon. It is in the anterior calyx, which is narrow infundibulum with the tip of the stone burden that you can see, which is being laser fragmented, and you can see the suction scope then enables visualization with suction of the fragments. This is indeed beautiful, reduces the risk of leaving any large burden stone. Most of it are fragments that can be washed out, even in patients where the tidal volume is so high, the kidney is moving about. And all credit to the anesthetist who is trying her level best to keep the kidney still for us. And this is a wonderful case where you can use the suction to enable better visualization. And this is even more so in patients who have significant matrix. In the olden days, before the use of the suction scopes, one could only flush out the matrix and hope that they would wash out. Now you can literally suck out the matrix, use a collecting the gynecologists use for the sucking out the products of conception, and you can get the matrix for analysis. So these are some of the salient benefits of this suction scope. There is less ureteral access failure, like in the paper published recently by Ali Teleshinsky, there is only a 0.9% failure rate with the 7.4 French access sheath. The benefit of this is also one can use smaller caliber ureteral access sheets. So I have now come to just using 10 to 12 access sheets. So the need for dilatation of the ureter, the risk of damage to the ureter is quite low. And I may go a bit more challenging as we move into ureteroscopies in patients who have had multiple CT scans, pregnant patients. One could even consider radiation-free procedures. And more importantly, also think about one's own ergonomics. The recent workforce paper by Steve Payne and Ian Pierce have quoted our working lifespan as a consultant with median 29 years. So to be carrying heavy ureteroscopes for that long is not feasible for any human being. So these are so much more lighter, and the wear and tear on your thenar eminence, especially if you use the reverse deflection scopes, is quite challenging and limits our working life. The limitation is the working channel flow. So if you use smaller and smaller scopes, then the worry is that the channel will be less, especially if you have an instrument. So one needs to also have smaller instruments. And in the development of these telescopes and, ureteroscopes, one should also look at the tip design and how much torque can be enabled in the distal end of the scope, so that one can reach small areas, calyceal diverticula, anterior calyces, especially in the lower pole, that where the stone is, and often a challenge for PCNLs. But it's not just about stones. And as you can see here, this is a patient who's had a cystouretrectomy, ileal conduit, nephrouretrectomy, and this is the single kidney patient. Decided patient will not want to go on dialysis, and this is a palliative tumor ablation. And as you can see, this is an interval recording which has been split. The initial part was lasering, and then there is the suction of the debris, suction of the clots, so that one can visualize the area better. There is some interference with high-powered lasering, and as you can see, a careful suction of the debris helps one visualize the tumor base. All this in subsequent videos, subsequent imaging had shown that it had all sloughed off. Now, 18 months later, he's still ongoing with a 3-monthly laser ablation as and when required, beating a palliative approach, which would have been a median lifespan of about 9 months. So these are the benefits, as I can see, which demonstrate the benefit of coming down to approximately 7.5 French. The smaller scopes are the way forward, but should we have an optimum size, because the working channel is important? Should we keep these special scopes for more complex patients with comorbidity, use suction scopes for patients with matrix, large volume stones, and use additional suction steerable access sheets if the large volume burden requires the fragments to be removed? Should we also identify the patients with narrow, tight ureters? And one could also argue that should we be using reusable scopes in patients who are run-of-the-mill 8mm stones in the renal pelvis, for example? But if you are in part of a group practice, you always have to check the fiber optics, especially when you're used to the really good optics of a video single-use flexible ureteroscope. Then to go back to using reusable fiber optic or video scopes, especially in diagnostic ureteroscopies or tumor management, is quite challenging because you're used to real good quality. And the other benefit is in patients who one needs to be radiology free and or stent free. Thank you.
Thank you very much, Joe. Yeah, I think the future seems to be going towards single-use scopes in all directions. And that ties in well with my talk. So I'm going to go next, and I'm going to talk about suction sheets and suction scopes. For those who are with us, participants, please, if you have any questions for any of the talks or for my talk, please feel free to put that in the chat box. So I'm going to talk about the suction scope and suction sheet, which seems to have a lot of buzz recently, especially given that suction seems to be the way forward, especially when it comes to residual stone management and so on. So these are my relevant conflicts for the talk. I think the future would probably involve suction in some way or the other, whether you're going to have a scope or a sheet. So here we've got the piece and suction scope, the 7.5 and the Seplu 1012 access sheet with suction. I just want to point out here that if you're using the 7.5 scope, the differential of 3 French is probably very useful. If you use a much bigger access sheet with suction, then it sometimes collapses. So 3 French is probably ideal. So that's why if I use a 7.5, I use a 10, 12, and maximum 11, 13. I won't go beyond that. 10, 12 works very well, and it's still quite small and agile. So let's look at the innovation, development, and clinical adoption of ureteroscopy as a time trend. So right from 1954, there has been lots of innovations, and you can see different time trends, different time points through the decades, through the years. The last innovation actually is the suction scope. That was the Pearson 7.5. So actually, if we talk about the long list of innovations of flexible ureteroscopy, the suction is the last innovation that has been added to it. And hopefully, the future will be with different sized suction ports or having wider channels for suction. In terms of ergonomics, Ananda has showed the suction cystoscope. This is no different. You've got the handle, you've got the TUI port, which is attached, the fluid connector. So it is very similar, except in terms of the design, to the suction cystoscope. Now here you've got the port there, which is for the fluid management. You've got the TUI port for the laser. You've got the suction button, very similar to the cystoscope, and the deflection at the back. So these are similar to what you're used to, and the suction is connected to the spout there, which you can see, and you can move it on either side. So it doesn't matter which side your suction is set up, you can move it to either side, and it's controlled by a finger button. I find that very, very useful because then you are in charge and you can suck as much or as little as you want. So the main advantage, apart from what Joe has said about single-use scopes, is actually the integrated suction system that helps you to manage and maneuver a little bit better when you're operating, and I'll show some videos of that. So here I am. How does it work? So the same channel, where the fluid is connected on the other side and the suction is connected, and you can see it's intuitive. And actually, sometimes when you're sucking, you have to be careful because you do need more irrigation, because otherwise the irrigation runs out. But you just can collect. Now, just to also be very clear, it is not to suck fragments. If you want to suck fragments, you'll be disappointed. But it does suck the fine debris, etc. So here we are, a 48-year-old female with 2.1 centimeter renal stone, the histories of recurrent UTIs, and we wanted to use the suction scope for two reasons. One is to suck out the debris, and second, to minimize the operative time with low intrarenal pressure. So to get the best of this. So I'm just going to let the video play by itself. So in the end, we needed about just over half an hour, 32 minutes for this case. You can see when I'm fragmenting it, it is the fine dust and fluff that I'm sucking. It is not to suck the fragments, but what it does is, because it's sucking the debris, you are able to operate for longer without having to start, because otherwise the vision gets obscured. You're less worried about intrarenal temperature, pressure, because you are sucking intermittently. So as you're doing that, the pressure and temperature is less of a concern. If you were to continuously fragment, then it will be more of a concern. So again, you continue with the intermittent aspiration, intermittent suction as the fluid goes, and it really speeds up the process because you can laser for a lot longer. Once you have lasered completely, then you can, I generally go with pop dusting after that. So here you will see I've started pop dusting the stone, which means the stones are coming towards me. And the setting for that I use is about 0.6 to 0.8, 20 to 30, sometimes up to 40 hertz. And the stones are coming towards you. So once you start doing, in the end, you're left with fine dust and debris. Now, the debris and the fine dust will get sucked, but not the fragments. So once I've completed, as I'm coming out, you will see that actually the fine dust is getting sucked out. And I think that's the point, that you're not going to be able to suck the fragments out. But again, because you can go on for a lot longer, you're not that worried about lots of different things. The vision, as you can see, is very good. This is towards the end. It is just dust. And as I'm coming out, I'll use the suction again, which you are controlling, and you will see the fine dust and debris getting sucked out. So for me, we use it routinely now for a lot of our cases, not for every case. And here you can see I'm using the suction, and you'll see the stuff getting sucked out into the channel, which is quite good in a way. And you can have sometimes enough for stone analysis if you go on for a while, but it needs to be fine. This is a second case. This patient is young, referred from elsewhere with iatrogenic mid-ureteric stenosis and a low pulse stone symptomatic. And again, the idea here was to overcome the structure, which was quite a tight structure, and optimize the operative time. So I'll show 3 short videos in this. The first one is to do an endopilotomy with the 7.5 scope. I'm not using suction for this bit, but the smaller scope definitely helped. So here I am trying to do a limited endopilotomy, 1 joule, 5 to 10 hertz, to open it enough so I can get the scope in. Once the scope goes in, then you start to, so this is the second video. As the scope goes in, you can see there's a lot of dust and debris because it's a very dilated system. So rather than having to syringe it out, bit by bit by bit, which takes a little bit longer, more effort, you can use a suction to just continuously suck and get the stone closer to you. So that's another advantage. When you use suction, the stone, you can kind of manipulate the stone to come closer to the end of your scope. And then once you've done that, that's a stone in view. Again, I'll use intermittent suction to keep getting the stone closer to me because the system is dilated. So you can use the suction to manipulate the suction a little bit to your advantage. So as I'm doing it, I intermittently suck so the stones keep coming close to me. So especially in a dilated system, this can be quite useful. Here I am trying to move the fragment just by using the suction button. So it's not enough, but sometimes you can see that you can just manipulate the stone fragment just by using the suction button. So it's powerful enough to do that, but probably not enough to remove it completely outside. So what was my first impression? I think it was flexible, maneuverable, good vision, and suction allowed the clearance of debris and possibly reducing the operative time. So this is the first study, multicentric, from 6 centers, 5 European and 1 Asian center, that was recently published in World Journal of Urology. Prospective consecutive patients with 57 renal stones. The stone volume is reasonable. Cumulative stones diameter was about 18 millimeter plus. A lot of them had multiple stones. An integrated suction, when we asked the clinicians, was helpful in about 95% of cases. And as I said, you don't have to use in every case. Having that gives you the extra maneuverability or extra choice of using it if needed. Intraoperatively, 50 minutes mean operative time. Lasing time was just about under 20 minutes. Access sheet was used for majority. Remember, these are big stones, so I do tend to use access sheets where I can. Suction was helpful in majority. When we look at post-op results, the stents were there in about 84%. There was 1 minor bleeding. There was no other post-op complications. Stone-free rate was good, 84%. And for stone sizes bigger than 2 centimeters, again, it was quite good. The follow-up was done at up to 6 weeks' time. So we then asked the clinicians about different aspects. So about quality of scope, and if one was, not good, etc. So most of them scored very good, or between 4 and 5, similar with the pre-existing scope placement, visual quality, and so on. Most scored between 4 and 5. There were not really that much laser interference, and most people, if cost wasn't an issue, would prefer to use a suction disposable scope. So I think this clearly gives an indication that the scopes offer something which is of a good quality. Suction helps, maybe not in all cases, but in future, probably larger operative channel where you can actually suck fragments out. I know PCN is coming up with one. I think it's now going to be marketed in the UK shortly, and we are hoping to try to see whether the suction can actually suck fragments out, and to what extent and to what level would the fragments get sucked out. Is it 1 millimeter to, I think up to 1 millimeter or 1.5 millimeter probably would be able to, but time will tell. So we are waiting for that. So that is probably the feature of suction scope. What about suction sheet? So here you can see a suction sheet in action. You can see the degree of bend. It actually bends quite a bit. So again, the advantage is once the suction sheet is in place, because the tip is obviously flexible, bendable, navigable, and you use the scope itself to navigate through it. So here we are using a suction sheet. It's a hard stone. The idea is to break the stone, and normally you would leave it and assume that, it's small dust, it'll probably pass. But here with a suction sheet, you could bend it enough In the lower pole, it was a 2 centimeter stone, and you would see once I have fragmented everything, I will then use a suction sheet to actually bring out the fragments actively into the end of the suction sheet. So you're actively sucking out the fragments. And I think that is a real advantage at the end, because these patients would probably go on to get residual fragments or regrowth. So you can see that I'm coming out with the scope, and as the scope comes out, the fragments get sucked out in the side channel. Then you go back in, again, wherever you want to go, you go back in and do the same process again. And a few fragments at a time, you keep doing it. It does take a little bit of learning curve. It does take a little bit of getting used to. It may not exactly work how you anticipate in every case, but in most cases it works well. And you can see again, I'm coming out. So I use a Seplu sheet nowadays. It's probably most cost effective, but there are different sheets in the market. You can use any of them. And essentially the idea is to get to the scope, to the stone, and you can see, you can really navigate with the scope in place, get to wherever you want, and the fragments come out. In the olden days, you would end up basketing it. It takes longer, you get tired. It's very hard to basket the dust, the fine dust. Here, fine dust, fragments up to 2-3 millimeters, you can just get it out of the sheet with no problems. And I think that is a real advantage of using these suction sheets. And this is why I think it's a game changer, because one of the main aspects which we are not good at is prevention of residual fragments, because we know that residual fragments will grow in time. So this is a pediatric case which we had planned for a PCNL, but unfortunately the stent had retracted up. So we were going to, I think I'm going to play this video. So we were going to pull the stent down. We had to, and in the end we decided, okay, since we went up, there was not that much actually in the kidney. So essentially what we were going to do as a PCNL, we decided that we'll take the stent out, position it, and then we will probably go for a suction sheet and try and do it retrogradely. So what was a planned PCNL, here you can see the stone in the kidney. This is a pediatric patient, planned for PCNL, but in the end, we didn't do a PCNL. We used a suction sheet. We managed to break the stone and we sucked out all the fragments. So this probably will push the limits of what we can do. I'm not saying you should do it for all stones, certainly not. I think you'd still need to do a PCNL for staghorn or partial staghorn stones. But all I'm saying is there are certain cases where having a suction sheet will allow you to push the limit to do these stones retrogradely, which otherwise would have needed a PCNL. So here you can see lots of dust and debris. I keep breaking. Luckily, the stone is soft. Once we break it, you'll see the suction sheet in action again. And all these fragments, all this dust, debris, mucus type material, you'll see it's getting sucked out bit by bit. And once you start doing that, how much can you do? How much do you have to suck? How much suction power is needed? Some of the answers we don't know, only time will tell. And as I said, it doesn't always work as well and as efficiently in every case, but where it works, it is a treat. So in this case, it really worked very well for us. So here, after you fragmented everything, and I usually try and fragment before I use the suction sheet, because if you try and do it intermittently, you then have to go back, fragment a bit, suck a bit. I don't like to do that. So I fragment everything I can, and now you can see all the fragments with suction is coming out. And in there, we went in, it was completely clear for what would have otherwise been PCNL. So you keep going in and out, and you keep sucking out fragments, bits from time to time, till you completely clear it. And as you navigate the sheet into wherever the dust is, sometimes this dust you can see the dust will just follow, even when the scope is not going in and out. You will still be able to get the dust out. And I think this is a really good way of getting out big fragments. The question that some people ask, do you have to use a basket? I tend to for most of the cases, because sometimes you can see here, there's a little bit stuck there. Sometimes there's a bit of clot and the fragments are stuck on the clot. I like to remove everything. So I use it. You don't have to use it on all cases. In some cases, you might be able to just keep sucking out this way. Here you can see this is one of the last bits, almost like a mucus material. I'm sucking out and then it's completely clear. So I think this offers a very good way of clearing out stones, big stones. And there we are. This is the end view. remove just a little bit of dust, which is a dilated kidney, plan for PCNL, in there, and we did ureteroscopy. So there are different ways of applying suction for retrograde intrarenal surgery. You can do it via an access sheet, via the scope, via a special catheter. And I think intelligent pressure systems are going to come, which might even help us in the future to do a better job. Going on to the suction sheath and what is the evidence for that? So you've seen the evidence for suction scope, which was published recently. This is the largest paper on suction sheath, where patients, almost 400 patients with stone volume of 1260 millimeter cube, had a CT before and then 30 days, within 30 days of surgery. So these are all patients who had a CT after surgery, and the stone diameter varied, but most were between sort of 1 and 2 centimeter, but about 17% were also larger than 2 centimeter. When we look at it, TFL was used in about 46%. Lasing time was short, 18 minutes. Overall operative time was 49 minutes. One patient had blood transfusion, low-grade fever in about 3.3%, but 0 cases of sepsis. There was a low-grade ureteral injury in about 2%. And I have to say that sometimes there's a little bit of learning curve in navigating it inside the system. Now, if we take the stone-free rate as 0 fragments, on the CT scan, it was 58% as stone-free. But if we take up to 2 millimeter fragment, which is commonly accepted in urology, in endourology, it is 97%. So 97% patients on the CT scan, if we consider 2 millimeter as a cutoff, which is often considered, were stone-free. So this goes to show that actually the fans or the flexible navigable access sheet has got a very, very bright perspective. There were no cases of sepsis and very, very good stone-free rate. So is suction the future of endourology? I think there are several advantages of suction. The pressure control is a little bit better, or you're less worried, I would say, because you are intermittently sucking. Similarly with temperature, if you're lasering, you are worried about temperature. Here, you're sucking intermittently, you're less worried. Visualization is good. Probably you'll push the procedural limits because it does increase the speed of procedure and hence reduces the risk of complications like sepsis, which I've already shown you. Stone-free rate definitely is improved. There's no question of that. I've shown you the video, I've shown you the evidence. Definite improvement in stone-free rate, especially with suction sheath. So what are the disadvantages? There is a little bit of operational complexity. You have irrigation system, but you also have suction. I normally use a suction scope, and if I'm using a suction sheath as well, I just disconnect the suction scope. So during the procedure, I'm using suction scope, disconnect the suction, put it on the sheath at the end to remove the fragments. You do need a little bit more fluid than what you would normally use. The suction parameters, we still have to define it. We still don't understand it as well. There is more irrigation. So this is the most recent evidence of suction using ureteroscopy. This is a systematic review meta-analysis published just last week. 16 studies were included, analyzing almost, over 1,000 patients in the suction and standard groups each. And the application of suction improves stone-free rate, reduce infectious complications, and length of stay. So now you've got the evidence to show that suction improves stone-free rate, improves the overall and infectious complication rates, and reduce hospital stay. So I think, given that suction scope, suction sheet, you've got different ways of applying, but definite improvement in parameters and definitely here to stay. So what do we want the future to look like? We need smaller scopes. Of course, we need scopes that are least invasive. We want to dust it. We want to suck them out to clear it. Better monitoring of temperature and pressure. Maybe use artificial intelligence to predict outcomes so you can counsel the patient better and no recurrence. That is how I see the future. Any other questions? Otherwise, we'll take some panel questions and panel discussion. Thank you for listening. So I think overall, we all agree, and we've got some evidence to show that the suction use and smaller scope use is better. Can I ask you one question then to the panelists? It's open question. Feel free to answer. What do people think will happen to PCNL? Are we going to restrict PCNL to smaller and smaller indications? Or do we think we should carry on as we are with minimization? Anyone?
Can I come
if
in?
you are the patient, let's say if you are the patient, what would you prefer? Joe, you can come in.
Well, it's not, I would say it's also the patient population. So post-COVID, you're seeing a lot more patients who, if in fact, I was just saying that to someone on Friday, if the patient had cancer, the anesthetist, the surgeon would have said, sorry, we are not going to operate on you. Patient has come in sepsis. They have put a stent. With the ultrasound, you cannot see the kidney. So then the PCNL is not an option. And then you are under pressure with all these comorbidity. So that is number one. Number two, when you can do high-powered laser, when you can suck out the fragments, when you can do all these large volume stones in a single setting, maybe day case overnight, not only is it pushing into the PCNL area, but also it makes, like Yuko said, it also makes financial sense, especially in the NHS. So one may be finding that slowly PCNL will become the remit of only the very large stones. And when I say very large stones, I'm talking about not the stagons that need 2 or 3 tracks, because then again, the risks become higher. And I have a feeling that if the reusable single-use cost versus benefit argument from a cost enterprise and healthcare system is not there, like we don't have it, I think we will be becoming less and less. The numbers of PCNLs will be becoming less and less. Long answer for a short question, sorry.
So what you're saying, Joe, if I can put it in a gist, PCNL is not going to become obsolete. It will be there, but the indication might shrink.
Correct.
Ananda
Yeah.
and Yuko, do you agree with that, or do you disagree slightly?
I mean, miniaturization and minimalization in the access is there everywhere. So even if you say, for example, laparotomy has become like a laparoscopic access, then we gone into robotic access. Now the single port access is the choice. So it is heading towards that. So we already know with the good improvement of the flexible ureteroscopy, especially the reusable one, we have seen good number of reduction in the PCNL already. And now with the availability of more flexible, reusable or disposable ureteroscopes, and also with suction, we are now competing with the mini PCNL, and mini PCNL is competing with the standard PCNL. Standard single access PCNL is competing with the multiple access PCNL, because with single access using the cysternephroscope, we can reach the other calyces. So slowly the miniaturization, but without compromising the quality of the outcome and without much loss in the economic outcome also. Economic wise, we know how much the prices will come down once the user volume increases. So in future, I'm sure it will be more accessible even to the developing countries or even people who are struggling from the economic point of view. Yes, miniaturization is the future.
Yuko, same question. Do you disagree? Because you had to defend PCNL now. Come on.
I love PCNLs. I think it's also important to bear in mind that PCNL has become much less invasive over time, and therefore, like you say, you reduce the access sheath. It's really efficient, isn't it? And therefore, for a large burden stone, I think PCNL is always going to have a role. And I don't know if the rest of you have noticed, but I do think that after COVID, the burden of larger and larger stones has increased. And the sort of dwell time of encrusted stents and things has increased as well. So I suspect that it probably will still be a while before PCNL disappears.
So then the same thing again, do we think that actually, because we do so many more ureteroscopy, there is a comfort factor. Because we're doing less PCNLs, there is a discomfort factor. Some people might use a radiologist. So does that volume play a role as well? Because, okay, we have been in the business for a long time, but for newer people who are coming in, trainees who are coming in, because the exposure to ureteroscopy is so much better, sheets are better, there's suction, etc., there'll be a natural drift in the new generation towards ureteroscopy than PCNL because of opportunity, because of training and so on?
I wonder if, I think sort of urology access to for PCNL has increased in popularity within the UK over the past couple of years. And therefore, we're not necessarily reliant on a radiologist to come. And therefore, yeah, I think, again, sort of hopefully trainee ability to deal with the whole PCNL has increased over the years. And therefore, yeah, I again do think that there'll still be a role for PCNL.
I slightly disagree, but I'll let Joe and Ananda give their views.
In my institute, how we handle it, we have 2-3 endourologists. So at least one endourology will keep the PCNL flag flying, so that the other one can push a little bit of PCNL cases into a flexible ureteroscopy. But the thing is, we should be able to finish it in one sitting. There is no need for a second sitting, etc. And so that the trainees who rotate with us will get the full spectrum of both the PCNL and ureteroscopies once they complete with us.
Joe?
I have to be a bit philosophical. I have seen the 60-plus-year-old consultants in the nearby hospitals retiring, who did probably 60 to 75 PCNLs in their time. And as the younger people come through, exactly like you said, I have a feeling that the comfort zone is the ureteroscopies and PCNLs. So I did train to do my own tracks in Birmingham. Then I came to Bristol, where the culture was the interventional radiologists who are really good. So I never did my own tracks. But it's not just us. So you have the team, you have the anesthetist, you have the IR. So you can see that if you do, say, 10 or 12 or 15 or even 20, 25 PCNLs a year, you don't do enough to get a well-oiled machine. So, I mean, a single example would be the matrix stones. If you see matrix on the CT with Hounsfield unit, recurrent GTI, large BMI, you immediately think, okay, let's go for a PCNL. Now you have the suction scopes, you have the sheets. So the encroaching on the indications is happening. There is less and less expertise. And I think people are becoming more and more used to doing flexible ureteroscopies. Because when I was training, flexible ureteroscopy was for the dedicated endourology trainee in his or her final year. Now everybody does that because you have the single-use scope. So I think there is scope encroaching. And I think we will find that maybe even PCNL might become a centralized procedure.
Thank you, Joe. And Yuko, I agree with you. Sometimes it's about who is doing the track, but I think this is a little bit more than that, because I think there is an overlap. There's an indication overlap as the single-use scopes become smaller, cheaper, laser become powerful, and you have suction. So what is the ultimate goal is to get stone free. And the suction, the paper that we have recently published shows that up to 18 to 20 millimeter, the stone free rate is up to 97% for minimal complications. So all I'm saying is, no matter who does the suction, because we do maybe, 100, 200 ureteroscopy and maybe 20, 25 PCNLs, and those are for more difficult stones. So the familiarity with simpler stones probably will mean that ureteroscopy is going to compete strongly. Thank you so much, all of you, for your views. It has been a real pleasure. I hope the audience who are still with us, thank you so much. I know you didn't have any questions, but hopefully with a bit of discussion, we have thrown some light into the future. Thank you again to Phoebe and George from CJ Medical, to Team PISN, and to the panelists. Joe, Ananda, Yuko, you've been great. Your talks were excellent. So thank you once again for joining in.
And thank you very much from CJ Medical. We really appreciated your presentations tonight. They were exceptional. And for anyone that has any further questions, please feel free to contact me at marketing@cjmedical.com. I can pass these on. Any questions I can pass on, or anything, any resources you may need, I can also send them over. So thank you very much, and have a lovely evening, and thank you to the faculty one more time.
Thank
Good
you.
evening,
Thank
everyone.
you.
Bye.
Bye.